morning again. My name is Mike Richards, and I'm the Vice Chancellor of Clinical Affairs for the UNM Health System. And I'm the co-chair of the search committee for the CEO position of UNM Hospital. My other co-chair, Dr. Jerry McDowell, who's also chair of the UNM Hospital Board of Trustees, is here today. And we both welcome you and thank you for being a part of this incredibly important process. Today we have the great pleasure of having Mr. Herb Buchanan provide us with the town hall. Mr. Buchanan most recently served as president of Methodist and University Hospitals, which are the academic medical centers for Indiana University Health in Indianapolis. He was responsible really for combining those two hospitals into the academic medical center of the future. That meant that he was responsible for the strategic vision and the priorities of those hospitals in alignment with the overall health system. He led the initiatives that included planning the facility, combining the medical staffs, the leadership teams, and all of the services into the new academic medical center of the future. He was also really important in implementing significant changes which resulted in improvements in both quality and safety, team and physician engagement, and overall financial performance of that institution. Prior to Indiana University Health, Mr. Buchanan was the Chief Executive Officer at Howard University, an academic medical center in Washington, D.C., and Chief Operating Officer for the University of Maryland Medical Center, which is an academic medical center in Baltimore that is internationally renowned for its shock trauma services in Baltimore. He also served as Vice President of Operations of Northwestern Memorial Hospital in Chicago and Vice President of Operations and Process Improvement in Huntsville, Alabama. Mr. Buchanan has a committed career to transformation of healthcare. He has done this through participation in many organizations like the American Hospital Association and other organizations. He especially has devoted his time to developing young people and has served as a faculty in graduate and undergraduate education programs in healthcare administration. He has participated in a broad array of community programs, both as a board member and as a volunteer. Mr. Buchanan is a native of Washington, D.C. His educational background includes a Master's of Business Administration from Northwestern's Kellogg Graduate School of Management, and as well as graduate and undergraduate degrees in mechanical engineering from the University of Michigan and from the Massachusetts Institute of Technology. So please help me welcome Mr. Herb Buchanan to the stage.
So good morning again. I'm double mic'd, so are the mics working? They're not? You can't hear me? Okay, so for the rest of the presentation. All right. So Sarah tells me that you're a friendly bunch, so you're not going to disappoint me, right? Okay, I'm going to, if I make sure these mics are working, I'm going to try to get a little bit away from the podium. But I'm going to tell you that on the walk over here, Paul was telling me that you're expecting 70-mile-per-hour winds. And I recall reading in the Wall Street Journal on the flight over here that one way an organization can tell they found their next CEO is on the day they do a town hall, there's 70-mile-per-hour winds. So I could save you time. We could dispense with the rest of the town hall. Okay. So here's what we're going to do for the next 30 to 40 minutes, however it flows. I'm going to give you just a little bit more about Herb Buchanan with reference to the topic. Academic teaching hospitals, where does UNMH fit in? How is it transforming the future? What's the relationship with the community? So a vision of that, the role of UNMH and the CEO in the future, and then some transformative community relationships, because I know you're doing a lot in the community. You've got a mission and vision that includes a lot of community engagement. So we're going to talk about how that might look in the future. One of the things I'm going to ask you to do at the outset is just to relax. Everybody looks fairly relaxed, but I want to assure you that this has been an extremely thorough process, and you've got 3 high-quality candidates. I want to applaud Dr. Roth, Dr. Richards, board member Jerry McDowell for the process you've gone through, so you at least know that you're in good shape. When you've had a long-time CEO, someone that you've gotten to love and respect and has led you for a long time, and there's a transition, I know there's a high level of uncertainty. But I can assure you the process is thorough, and when you get to the end and choose the right candidate, that you'll know that you found the right person. So As I was thinking about today and what we wanted to talk about, just reflecting on the process, one of the most difficult things to do is to project into the future, what is this person going to be like once they're on campus? During the process, everybody's on their best behavior, they're saying the right things, they're impressive, they're showing off their resume. But what you may be thinking about is 3 months, 6 months down the road, a year down the road, what is this person going to be like? When they do rounds, are they going to be approachable? When we're in meetings, is this going to be a good person to have, or will we be very happy the day that they don't show up for a meeting? When we get into the tough conversations in the community, what we're trying to accomplish, what we've struggled with in the past, when we're in meetings with physicians talking about resource allocation, joint planning, is this someone who will listen, who will respond, who will roll up their sleeves and collaborate, who will be committed, strategic, forward-thinking, all of those things? The tough thing to do is to get beyond the town hall and everything else and say, what's this person going to be like once they come on board and we have to work with them day to day and in board meetings and so forth. So I'm trying to give you a sense of that. So here's some things that are profiled. You can tell clearly that I have a sense of humor because the only person who thinks I qualify as most interesting is my mother. So collaborative, certainly collaborative in planning, in goal achievement, in decision-making, all of those things, collaborating with physicians, with board members, with community members, with team members. That's something that I've worked on my entire career. Approachable and engaging. One of the first things I hear when I come on board is that he's very approachable. You can talk to him about what's going on. You can tell him the real things. You can tell him what's on your mind. You can share those things. So I think approachable and engaging will be an important quality as you get to know a new CEO. Innovative and adaptive. We're going to talk about some things that are happening in healthcare that is a dynamic environment that will continue to change, and we're all trying to figure out, particularly academic centers, where the future is going and how to best position ourselves. So the environment is going to have to be innovative and adaptive. You're going to need a leader who's comfortable with that. Forward thinking. If you're not forward thinking in this business, you're lost. The things that made you successful in the past won't necessarily make you successful in the future. Trying to figure out what direction things are going in, working with new folks in the environment, new training methods, new translational research. You always have to be forward thinking from how you're planning a new facility, how you're engaging the community, how you're responding to the economic pressures. Focused and disciplined. You've got an ambitious strategic plan, an extremely ambitious strategic plan that's hitting all the right things. In order to get that done, you've got to be focused and disciplined. Resources can only go so far. So you're going to have to use partnerships and relationships and leverage those better. You've got to find some new efficiencies. And so a focus and discipline approach will be very important. And then service and community oriented. From my discovery and my visits here, you are as committed to community service as any organization that I've become familiar with. And that has to continue to be reflected in the decision making and resource allocation and how we reach out and develop partnerships in the community and how we respond at the board level and make those decisions. So throughout my career, I've been service oriented. The reason I got into healthcare was to deliver services to those who need it and to try to help the industry transform to be more responsive. We're seeing that happen throughout the country, and this organization has the potential to be a leader in that. So as you think about the future and you think about your decision making and think about beyond this day, what would it be like to work with her, Buchanan, or one of the other two candidates who are going to come regardless of how well we go today. We want you to think about how would it be like to work with this person and hopefully get comfortable with that. So now, as we think about the future, what are we expecting academic teaching hospitals who are always at the forefront of discovery, and not only in clinical discovery, but in processes and training? What kinds of things do we need to be thinking about? And I'm not going to pretend to have a crystal ball, but just how do we think about the future so that we're best positioned and we're nimble and we're flexible? So certainly, you've got a local presence, you have a statewide responsibility, and you certainly have an opportunity to be national leader. I truly believe when I look at your mission and vision and your goals, the things that you're going to accomplish over the next few years are something that folks from all over the country are going to want to come and see and find out how you did. So potential for leadership well beyond the city of Albuquerque and even the state of New Mexico. So now I took a snapshot of your mission, vision, and goals. And in the true spirit of PowerPoint, I'm not going to ask you to read the bullets. In fact, I'm going to ask you not to read the bullets. Because if you're not familiar with this, then Dr. Roth, Dr. Richards, and I need to have a whole nother conversation. But this is just to reinforce that the things that you're focusing on, what you're trying to accomplish next year and the next few years, are all the right things. How do we improve the health of the community? How do we do statewide? How do we focus on population health? How do we make sure we're hitting all the metrics internally? When we're talking quality and safety, ensuring that we're a leader, ensuring that we're using all of our discovery and all of our expertise and all of our commitment to be among the top in percentile. We have the opportunity to do that. So what do we need to do in terms of focus and discipline, in terms of tools, using processes, lean, things like that, to ensure that we continue to improve, to get to levels that make us proud and that the community can embrace and other organizations can look forward to see how it's been accomplished. So when you look external, reaching out more broadly into the community, developing new kinds of partnerships, ensuring that you're measuring the health of the community, improving the health community, educating the community, preparing future caregivers and learners to reach out into the community. You're focused on all the right things. And I've said throughout my visit here that one of the things that attracts me to this organization is you are as focused and committed as any I've seen in doing the things that people get into healthcare to do. So when I look at my own bucket list and say, what did I get into healthcare to accomplish and what have I tried to build towards in my career, it's all happening here. So when folks ask me, well, why would you consider UNMH? They're doing the kinds of things that I want to do. I would enjoy partnering with them and achieving this together, and I believe you've got the resources, the people, and the commitment to do that here. Innovation, discovery, creativity, making sure that the mindset of folks in the future is in that regard, developing leaders for the future. You've got it all outlined here, and so I applaud you for that and for your commitment to that, and it's reflected in your board discussions, it's reflected in your capital allocation, it's reflected in your strategic planning. That consistency is extremely important. So as we think a little bit more about UNMH as an academic teaching hospital and how do we best accomplish those kinds of things, there's certainly things that we have to do or do better in the future. Collaboration and partnerships. In my view, relationships and partnerships are going to be the key to future goal achievement. You've got a lot of well-established relationships that will have to be leveraged. When you look at what you want to do in the city of Albuquerque, in the state of New Mexico, eventually you're going to tap out on your resources. So how do you extend that reach? By developing new and different relationships. And I'm talking about with the partners you've already got, with the Pueblo community, with the YMCA, with the churches. Some of these you have in place. Some of them will take different shapes and forms. Some of them will be leveraged differently. Even some of your competitors, Presbyterian and Lovelace, you've formed some relationships with as you think about future transformation of healthcare and delivery in the city and even approaches outside of the four walls of the hospital. Working with those partners differently, service collaboration, figuring out how to reach out, to improve the health of the community, population health. Imagine how much farther your reach can be extended if you're not talking just about UNMH. And sometimes when you get to the point of full extension and you believe you can't do anything more, engaging those partners and talking about doing things differently can extend that reach. So perhaps in those conversations you can get beyond the no that you had at one time and more towards we can't do it that way, but perhaps we can do it by leveraging those partnerships. So I truly think relationships, just like they're happening in other industries, are going to be the focal point of healthcare. And when you think about, quite often when I talk to audiences and I mention Amazon, at least the ladies nod and say, Amazon Prime, are you kidding me? But when you think about Amazon and Whole Foods as an example, that's a relationship that few of us in this room would have envisioned, even if you're studying Amazon. But clearly Jeff Bezos and his team and the folks at Whole Foods thought about food and delivery and maybe grocery stores in the future, but they were focused on relationships. And so with billion-dollar investments in Whole Foods, somebody there is betting on that relationship being more than just the sum of those parts. So I think there are opportunities for that in healthcare. I know there are opportunities in healthcare with physicians, with community members, with public health services, with the government, you name it. exploring those relationships and partnerships the way other organizations have done in other industries, I believe brings a lot of potential to healthcare. Empowered teams and team members. I've been asked in many conversations, what's your approach with team members, emerging members? How do we do a goal achievement? The best way is to hire and train a committed workforce and then give them the resources and turn them loose to do the best job that they can do. In my experience, most of the folks who get into healthcare for the right reason. And they wake up and they come to work every day to deliver the best possible services. They're invested in the community, they're invested in patients, they're invested in whatever services they have responsibility for, and hopefully the organization. And so empowered teams make all the difference. If you're just relying on a few people to bring solutions, to help you improve service levels, team engagement, then you can only go so far. But if you get everyone engaged and empowered in everything from how do we achieve these, how do we raise our engagement scores, how are we more responsive to patients, how do we do follow-up outside of the hospital, empowered teams can get you there. The resources that you have within the organization, they're creative, they're talented, they're young, all of those things that you need in the future. So empowering them puts the organization in a much better position. I touched a little bit on transformative relationships. Being creative and thinking about the relationships we've had in the past and developing new ones in the future will be critical. As the new challenges emerge in healthcare, we're going to have to be extremely creative about how we approach them. If we continue to use the tools that we've had in the past, we're likely to come up short. But if we can be creative and transformative and think about them differently, even the term competition in healthcare is changing. When I got into this business, the hospital across town or across the street was a competitor. We didn't do anything together. We didn't share anything. Now you're seeing folks talk about delivery of cardiovascular services, purchases of high-priced equipment, and there's more opportunity for a community-based approach. So you're not just spending in a competitive environment, but you're talking about improving the health of the community, which really is the bottom line. So if you can get past that competition, and I truly believe in most communities, there's enough health care to go around to keep organizations healthy. The point is, how do we do that with the right goals and the right resources so that things can stretch further than they currently have? Adaptive teaching and training models. The wonder of being on an academic campus is you have got all these schools and all these students and all these professors, and they are doing some fascinating things. And I will tell you, in the past, in academic centers, we've not done the best possible job of reaching out to tap into that forward thinking. Solutions are being developed that could be applicable to healthcare. You've got great minds on campus that if you brought them in to some of these problem solving and address some of these challenges, you've had some innovative solutions. Technology, finance, law school, some of the things we've been working with for decades in healthcare have solutions that I think are right here on campus. So doing a better job of reaching out to the community. One example that comes to mind at University of Methodist Hospital in Indianapolis, as we began to build what we referred to as the academic health center of the future, we engaged fellows and residents and business school students and other students to talk about workplace environments for the future. When we build a place that's going to be standing for 10, 15, 20, 25 years, what kind of flexible workplaces and functional workplaces do we need? You know, I've been in this business for decades. When I think about future workplaces, that scope is rather limited. But when you ask someone who's doing Instagram and Facebook or who's been to school with creative learning methods, they're much more appropriate source of information of how are training methods going to evolve over the next 15, 20 years. So how do we build flexible workplaces? Just as an example, the level of engagement was extremely beneficial to us as a team. And of course, those whom we asked were extremely excited about that opportunity to build something that they were going to practice in the future. So we were much more confident in the final product because we were listening to and talking to the right people, and that can spread. And they went back and told their colleagues, they're doing something exciting over at the hospital, you need to get engaged. So I think there are many, many opportunities on this campus as we think about future facility, future healthcare delivery, training. I can also share with you that some of our training methods for physicians, for nurses, for pharmacists could use a little upgrade, to put it mildly. The old model of, I'm going to go way back a little bit, but 20 folks coming into a room to see a sick patient and the physician talking about what's going on with that patient and not talking to that patient, those days are past. Patient expectations have gotten far beyond that. They're expecting to be the focal point. And even though you have to train caregivers for the future, they don't want to be the crash dummy in the room who's referred to as a disease entity. They want to be communicated with. And I think the learners have even thought, because of the environments that they've been brought up in now, they believe that we can be more creative and forward-thinking in how we do that. So as we think about facilities and processes, incorporating that into the future will be very important. Disruptive technology. We see it much more, I believe, outside of healthcare, but the rapid rate of change in technology needs to be incorporated in healthcare. And I'm not just talking about the Cerner and Epic debate. We all believe, I think, that we'd like to see a lot of improvement in the delivery of those services. But whether you're talking about apps or use of social media, many of our challenges that we've been working towards for a long time in healthcare could be enhanced by disruptive technology. And when you read about technology and you read about what's happening at Google and Facebook and other places, even as they begin to dip their toe into the healthcare waters, there are many things on the horizon that I believe academic medical centers need to be at the forefront of and can help develop. So reaching out to them to explore those, I think will bring a lot of solutions into healthcare. Mega community, I'm going to come back to. It's a phrase that maybe you haven't heard before. The simple definition is it's an approach where the old-fashioned everybody getting together in a community and solving a problem is achieved at its highest level. Leaders from organizations come together to solve a problem. Anyone can be the leader of the YMCA, the leader of the pastor of a church can be a leader, but it truly is to solve a problem. And people come and drop their titles at the door, and they just roll up their sleeves and talk about what needs to be done. There are some examples in third world countries, in Harlem and New York, where leaders have brought folks together from General Electric, from schools, from various backgrounds to talk about problem solution that didn't require a GE investment. It wasn't a business opportunity. It was just folks bringing their expertise to the table to say, how do we improve the health of the community? How do we get water to an area that's arid? How do we develop solutions? How do we do business development in a community in Harlem? So it's a fancy name, but it really is that old-fashioned folks from the community getting together to solve problems. Imagine the implications that could be in healthcare, and it's not that hard to do. It's a proprietary approach that was developed at Booz Allen and happened to be developed by a gentleman with whom I went to school. But it really is an approach where you can get constituents together. And for example, the CEO of the hospital may be invited into a rural community to talk about what's going on and not asked to bring doctors, not asked to spend money, not asked to set up a clinic, but just asked to bring some expertise. You folks have done some things throughout the state. You can help us talk through whatever it is that's trying to be solved in that community. And then finally, advances borrowed from outside of healthcare. There are many solutions that we're just beginning to explore from other industries that could be brought to bear in healthcare. And that's everything from simplifying the billing process, to improving the use of technology, to training, to lean, to all of those things. Another example I'll share, as part of the process of designing the Academic Health Center of the Future, we brought together a group that we called the Big Idea Group. And the idea was to get folks from all kinds of industries to come in and, one, give us a look from some of the breakthrough things they had done in their various businesses, but also give us a look at healthcare from folks who weren't wrapped up in healthcare. And they asked all the questions that you would ask. Why do you do things this way? Why can't I understand my bill? Why do I have to talk to 5 people about the same problem I discussed at length my last visit here? Why don't you know what happened in my physician's office? Why is there a wait? Why do you advertise, I want you to come to see my endocrinologist, and then when I call, there's a 6-month wait to see the physician? Folks outside of the healthcare industry won't accept that. So what these folks did, one was give us a critical eye as you're thinking about the hospital of the future and the processes in the future. Give us a critical eye on things that absolutely have to be addressed if you truly want to be an organization for the people. And then secondly, folks, there are some solutions we've been doing in other businesses for years that could solve some of the problems that you continue to tell us are plaguing you in healthcare. So some examples of how to achieve those pillars that I believe will be critical to the hospital for the future. Once again, the goals and the pillars that you articulated are on point. And I applaud you for continuing through your strategies, through your communication, to impress upon those. That's the model for the future. If you can't develop a culture of excellence, goal achievement will be minimal. If you're going to tell the state that you want to improve their health and you want to be their destination of health, that you want to transform their thinking and their learning about healthcare, then you have to be an excellent organization. You have to have operational efficiency and financial strength. Whether it's revenue cycle, whether it's expense control, whether it's getting most out of your resources, whether it's hitting your RVU targets, efficiency will be critical because your desire to do things in your strategy, in your community, are ambitious, and they're going to require a lot of resources. And the resources are finite. So in order to better leverage those, you're going to have to become much more efficient. So that needs to be, of course, on every academic medical center's vision and goals. And it's good to see that highlighted. Strategic growth and partnerships, working with physicians to achieve those will be very important. The patient experience, everyone's talking about the patient experience. So how do you get a breakthrough? I've been involved in various and sundry approaches to improve Press-Ganey scores, and everybody in this room more than likely knows how hard it is to gain some ground on the percentiles. And I've seen many engagements launched, and I can tell you from a personal perspective that I've been disappointed in the results. We need some breakthroughs in the patient experience. There are things we can learn from folks in the service industries, I think, that can help us achieve those breakthroughs. There are relationships and conversations we can have with the community. And I know that you've got quarterly community meetings, you've got patient panels, so you're in the right place, you're doing the right things, but to have a significant improvement, we're going to have to do some things differently. And we've experimented with some things in the past and had some gains, but for truly to have breakthroughs, to be known as the destination of choice, best place to work, we're going to have to explore and try some things that maybe folks have done other places to really achieve results. Certainly the culture has to be one of commitment to service and quality and safety, but to have some techniques to really improve the percentile significantly, I believe we're going to have to find some breakthrough methods, and those come from engaging team members, engaging folks outside of the hospital, maybe even outside of the industry. So another look at this mega community. We touched a little bit on partner hospitals. I know you're doing some things with Presbyterian and Lovelace now. I think if you take a snapshot in the future, those conversations will continue. Whether it's collaborating on a service or whether it's looking at what's most appropriate to do at UNMH and what others can do better. One of the things we took a critical look at as we were planning the Academic Health Center of the future was, what are we the best at? What are we doing the most of? What's our bread and butter? And how do we start there and build beds and diagnostics and have resources to, let's start from there, and then we'll go. What you usually end up doing, of course, is running out of money and running out of resources in the planning stages. So if you start with the things that are most important, and of course, every chair believes that their services are most important, but you have to strategically decide what's going to drive business, but more importantly, what's going to be best for the community. What services are we continuing to develop? Where do we have breakthroughs? And how do we focus on that? And then with concentric circles, what are the other things that we're doing that maybe doesn't need to be done in an academic center, maybe can be done with a sister hospital or with a partner hospital. And does that fit into the strategic plan? And we're talking beds, we're talking capital, all of the above. So those relationships could change. There are things that we're just beginning to talk about doing with partners that we used to consider as competition that maybe could benefit us in the future. Maybe there's some joint things we can do. Maybe there are things that we can do with beds. If you really want to do some wild thinking, as you look down the road at the next MRI, the next CT, millions and millions of dollars, in the old environment, Hospital A would buy one, Hospital B would buy one, Hospital C would buy one, and the community needed one. So when you talk about healthcare expenses, you spent $3+ million on each, $9 million in the community, and you needed one. So $6 million was spent that wasn't needed. But if the first hospital got one, the second one had to have one, because you certainly couldn't go to the patients and say, well, we don't have what they have down the street. But if you can imagine for a minute more collaborative planning, perhaps there's one. Perhaps the 3 hospitals either agree to purchase one or to leverage the use of one so that you don't have that excess capacity in the community, and then those dollars can come towards other resources. Now that's heresy. It's heresy in the old way of thinking, but just an example of ways that you can look at specific resources and redirect those resources because you're truly focused on community need and not just buying because someone else wanted to buy one. Now please don't go back and tell radiology that I'm advocating we're not buying the next MRI. That'll be a non-starter for me. But I'm just trying to get you to think a little bit about competition differently, and I believe academic centers can be a leader in that. I mentioned university resources earlier. I truly believe that you've got the best and brightest minds on campus. Inviting them in for conversations can truly be beneficial. I've seen it happen in the past. I know it can happen here. So reaching out to the deans, to the researchers, to the students, tremendous potential that could be tapped into. Community health providers, you are doing as much from my limited exposure here as anyone in the country of reaching out and engaging the community, having conversations, opening clinics, putting folks on the board, establishing covenants for bed use and all of those things. You've got those relationships established. Continuing to talk to the community and being a presence there and exploring other solutions. When you think about mega community, those could be solutions beyond healthcare. And once again, I'm not talking about just writing checks. It could be lending your expertise. It could be helping them solve a problem because you've done something in parallel. Imagine the goodwill you develop in the community when you participate in a conversation that has nothing to do with you getting another patient, with you getting another dollar, with you expanding your services, but just being a servant in the community and wanting to participate in solutions. And so just being a part of that conversation, imagine the goodwill that would come from that, just from bringing that expertise to the table. And it doesn't have to cost you a dime. It could just cost you your time. Major and minor employers, reaching out to them differently. The relationship we've had in the past has been trying to get their business, trying to do insurance work with them, trying to make sure that we take care of their staff when they send them to us for care. But there are other relationships that can be developed. They can bring some solutions, once again, outside of those formal relationships. Advances that they've done, maybe things that they've done with their team members that could be used for UNMH team members to improve engagement, ways that they approach problem solving, ways that they meet, ways that they do work from home, all of those creative things that are happening outside of the industry. Developing relationships with employers can be extremely beneficial and maybe even lead to conversations about better ways of developing the formal relationships, insurance-related, service-related, and so forth, to change those conversations. It's difficult to sit down every year across the table and talk about pricing and numbers of people and whether folks were satisfied with the service. That will likely continue, but if you can develop more collaborative relationships, that would grease the skids a little bit for some of the formal things we have to do. Services, there are things that are happening in the hotel industry, in the financial industry, Google and so forth, just some cool stuff. Just cool things that if you stretch your mind a little bit could be applicable to healthcare. So just having initial conversations with them about some of the things that are emerging in their organization, flexible workspaces, meetings where all the executives come and answer questions, using technology to solve problems or to leverage time, all of those things, the exploration is just expanding exponentially. And so bringing some of those solutions into healthcare will be extremely beneficial. And that's really, when you think of innovators, we'd like to be an innovative organization. Academic medical centers pride themselves on being innovators. So how do we learn from innovators? Everybody on that list is on the Forbes list of most innovative companies, and they're doing things to be recognized nationally and internationally. So tapping into how other folks innovate can be extremely beneficial. And maybe there's some things they can learn from us as well. But I'm always fascinated by reading articles about how eye care was delivered in a cost-effective method throughout India. When you talk about a place with a population and with rural reach that's required and limited resources, opening up an eye clinic just seems like a non-starter. But I have followed this organization for years, and they are now internationally celebrated for having clinics throughout India. And they do it and make money at it. And I would have told you that was impossible when they got started. But they've got some innovative methods. And there's probably one person in this room that owns a Tesla. I don't know if they're ever going to make any money with Teslas, but it's pretty cool to see the electric cars on the freeway and them being able to go from 0 to 60 in 6 seconds. I never thought that would happen. So once again, I'll talk about internal and external relationships and maybe some different ways of thinking about it. Physician engagement. There isn't a place you go to in this country where physician engagement isn't listed as an opportunity. Whether you've got low engagement scores or you're doing pretty well, but you've got opportunity for improvement, everybody wants to talk about ways to better engage physicians at all levels. I'm talking about med students, other learners, I'm talking about fellows, residents, chiefs, formal leaders, informal leaders. Engaging physicians is critical. In an academic center, if you can't engage your partners that you're working with every day, you can't expect to have goal achievement. We have to find new and creative ways of engaging physicians. They tell us clearly, we want to be involved in decision making, we want you to be transparent, we want to be collaborative, we want to get rid of the old model of administrators being an administrative suite making decisions and then informing us about what they decided. And we want to get beyond this resource allocation conversation every year where we feel like we don't get what we want and we weren't part of the conversation. So engaging physicians is critical. One of the first challenges I faced in Indianapolis was overcoming a history of a lack of engagement and a lack of focus on the most important priorities. And we had to set an infrastructure in place that included communication, individual meetings, group meetings, regular meetings with chairs, meeting with physician leaders, communicating in every way possible to make it clear to them that we heard them and we wanted to engage them. The planning for the academic health center of the future, the budget, as we talked about all the services and our approach to them each year, we had to do joint planning so that we had complete alignment. Funds flow conversation, the list goes on and on. We have got to change our physician engagement, and the only way to do that is to engage in conversations and ask what they're looking for. What worked in Indianapolis may not work in Albuquerque. What worked in Baltimore didn't work in Indianapolis. So you start with a conversation of what are you looking for, what does engagement look like to you, and then how do we achieve that? Informal physician leaders, every academic campus has emerging leaders. We have to invest in them, we have to train them, we have to talk to them about what they want to do in their careers and ensure that they find a place to do that on campus. So we have to be clear and transparent in that investment, whether it's a leadership institute, whether it's formal training, whether it's just opportunities, giving them more and more of an investment so that they will be our leaders of the future. Fellows and residents, beyond just training, they have a lot to bring to the table. I mentioned just one example of planning, but fellows and residents are in that sweet spot of folks who are going to be running things in the future and who have done all kinds of cool things as undergrads and outside. and are on their phones all day long and following Facebook and following Google and all of those things, they've got some creative ideas that certainly could help us better position ourselves for the future. So finding new ways to engage them, graduate and undergraduate students, brilliant minds once again. And the CEO certainly can be a leader in reaching out and engaging those and having those conversations and multiplying those conversations for goal achievement, to face challenges, even for things outside of the four walls. Professors, interns, I mean, there isn't anyone on the team that we can't benefit from engaging. And certainly the approach in the future, the leader has to change the way that's been done in the past. And that's not to indicate that you don't have strong relationships or you don't have successes. But as you look to the future, this campus has to be known and a place that engages everyone and taps into all of those resources. So anyone who's willing and able, certainly let's have those conversations. And that, I don't mean to indicate that the CEO is in the center of all of those, because I'd be doing nothing but meeting. But certainly facilitating those conversations and establishing a culture where they're comfortable and where they're requested having those conversations with them as a senior team. And similarly, as you talk about the external focus, relationships in the community to achieve all of the community services things you're targeting have to continue to evolve. And talking to the community about that possibility will bring some things to the table that you haven't even thought of. You know, a couple folks have asked, well, what do you see things going in the future, and what would you do day one? And my response has been the same. I want to talk to folks about what their ideas are. I could lay out a vision with specific steps today that would be as informed as 5 days on campus would allow me to inform. That, I can tell you, would not be a very good product. But if I spent 90 days, 100 days engaging the community internally and externally, talking with folks about relationships we've had in the future and how that can be improved, talking with them about creative ways of collaborating, other things that we could do beyond just extending resources, then the conversation can change. So a transformational leader has a different approach tomorrow and next year than what you've got today. And that's informed by you, it's informed by the community, so the community can see that we're a responsible steward of our resources, but community resources as well. And we're willing to engage with them in different ways to solve problems. Reshaping culture and developing talent. I'm a big believer in talent development. And part of the responsibility of the CEO is to develop talent for the future. So as you look down the road 3, 5, 10 years, ensuring that you've got an executive team that's up and coming. So regardless of the positions, you've had the luxury of having a CEO here for a long time, and very few organizations can say that. As you look to the future, you want to be comfortable that as the next team begins to move on, you've got that up-and-coming talent ready to take over. There are many ways of doing that with internal development, with external resources, with Center for Creative Leadership, with resources outside the building that can prepare the leaders of the future. So one of the prime responsibilities of the CEO and the executive team is to develop that talent so that we can have the conversation with the board and with the community and say, here are the up-and-coming folks. They've already been giving opportunities for leadership. We're already introducing them to you, so when the time comes, they're ready to step in. Trust me, it's a challenge to groom someone to push you out of a job. But I learned early on in this business, if you can't tell your boss about someone who's prepared to push you out of the job at the appropriate time, then you're not fulfilling your responsibility. Community leader and volunteers, once again, you're writing the book for community leadership. So certainly the candidate that you select has to be a leader in reaching out into the community and being seen as someone who's approachable. So even when you're having those tough conversations about things you haven't been able to do in the past, they see those leaders as someone who's engaging and listening. So maybe we can't do it this year, maybe we can't do it the way that you asked, but we can continue to have the conversation about what those needs are and possibly other ways of addressing those needs. So those relationships have to continue to develop. And I said at the outset, relationships really are going to be the key for the future for academic teaching hospitals and for the community. And so being seen as someone who's open and willing to have that conversation will be a tremendous asset. encouraging and talented risk-taking. Great leaders will tell you that if you're not taking risks, you're really not doing anything interesting. In order to best position for the future, you've got to try some things. And good leaders learn from failures. And I'm not talking about million-dollar failures. I'm talking about calculated risk. But to do something truly interesting in professional development, in service level improvement, and quality and safety, you've got to try some things that you haven't done in the past. And so encouraging folks to take calculated risk, to try some things differently, truly can lead to some breakthroughs. So hopefully we'll have an opportunity to encourage that. Board member relationships, and what I'm talking about here is beyond the traditional. Typically, when a CEO comes on board, they sit down with board members, they sit down with community folks, and they say, well, what couple of boards do I need to be on? That should continue. But there is a possibility of doing some things that have nothing to do with your specific responsibility for the hospital to show that you're a steward and truly a member of that community. So your relationships have paved the way for that. So certainly you would look to your leader to say what things are important to them and what boards have they joined, just to demonstrate that you're part of the community and not trying to get something to benefit from UNMH. Of course, you eventually will, but you really want to be someone who's a part of the community, who's a leader in that community, and who's willing to bring some resources and expertise to the table just because you're a leader in that community. And then similarly for the national healthcare leadership, I truly believe there are opportunities here for national leadership, certainly in what you're doing with the community and population health, but many, many other things, quality, safety, service, efficiency, all of those things, because you're focused on it, because it's part of your strategy, because it's part of your decision-making and resource allocation. So national leadership, and one of the wonderful things you have an opportunity to do in this position is go to meetings and hear about what other folks are doing. The first time I heard about a hospital bed in a home was at an AHA meeting I went to several years ago, and I was just amazed at the ability to extend the technology, but also the willingness of the hospital to establish a presence in a home. Now, I don't know if that's where things are going in the future. I don't know if you're talking about 300 beds at UNMH, if someone's going to say, well, 50 of them are going to be in somebody's home. For me now, that's a stretch. But certainly having the conversation and understanding what the drivers were and what the results are and what the potential impact on outcomes were, those are conversations at least to have. And so when you go to those meetings and talk about what's happening in other places and bring those back, those are good discussions, but also being able to share what we're doing here. I believe people would benefit a lot from what's happening here. And so you want a person who's engaged nationally to bring those solutions back, but also to share what's going on here and have folks coming to Albuquerque to learn about some of the fascinating things happening on campus. The last thing a CEO needs to do, of course, is to solve the great debate about red and green chili. Now, I'm told I would have at least till December, till Christmas to solve that. But I encourage you to pick a leader who can solve this debate. It's been going on much too long. So, make sure you ask the other candidates, are you prepared to take this on? Because Mr. Buchanan was. And I don't even mess around with peppers. But I'm willing to engage in this debate and help to drive towards a solution. That's how committed I am. So now I've been talking for a while. I certainly wanted to leave times for question and answer, including if you have questions about some of the things we discussed. But once again, in summary, I just wanted to share with you, just some thoughts about where academic teaching hospitals are going in the future. I've dreamed about having the kind of vision that some of the leaders and some of the companies I talked about have of knowing specifically where an industry is going. I have no idea. For academic teaching hospitals, certainly I follow trends, but there are so many changes and it's happening on the fly. I don't know where it's going to be 5 or 10 years from now, but I do know that to follow that path, what's required to best position yourself. So I'd like to be able to lay out for you the secrets of what's happening in the future in healthcare. I don't have a clue. Even the things that influence it are changing every day. But just some thoughts about how a teaching hospital needs to be a player in that, how we can maybe better leverage the relationships you have in the community to develop more, to have conversations about things that can be done differently, to ensure that you've got a transformative culture here, to invest internally so that people truly feel like they can come to work every day and bring their best and do their best, and the organization is going to support them, but also that they're working in a place that's considered best place to work, but a place that has their future in mind, so that their individual and team development is an investment that they can see on a consistent basis. And then as you think about your CEO of the future, what kinds of expectations should you have for them as a leader in this organization? So I'll pause there and open it up for questions.
So we have 2 microphones, and so if you could just raise your hand, we'll have somebody bring you a microphone. So while we're waiting for that, so Mr. Buchanan, I appreciate your courage for taking on the great pepper debate.
Sure.
Out of your comfort zone. That's very admirable. You know, one of the things that you're known for is your long career that has involved transformation of healthcare and other organizations. You know, I just recently listened to a lecture from the industry of transformation in healthcare. This was a consulting group who actually said that even in organizations that have a transformation agenda that's clearly articulated with a talented leadership team and a clear vision and a history of execution, that even with all of that substrate, it only happens 30% of the time. Mm-hmm. So what distinguishes organizations that actually can achieve that transformation from those that aspire to it?
Excellent question. The distinguishing feature that I've seen throughout my career and throughout my reading of literature is the culture of transformation. I'll give you an example of lean. 20 years ago, I remember being introduced within healthcare to Six Sigma, lean, and those kinds of things, and watching organizations take it on. And lean consultants were proliferating. They were going to every hospital. People were spending hundreds of thousands of dollars on lean, and it wasn't sticking. And if you walked around an organization, you'd see the metrics on the wall, you'd hear people talking about it, and then you went back in 2 to 3 years, and it was gone. It just didn't stick. And people continued to invest, but the organization didn't change. And I've been involved in 2 or 3 organizations that made significant investments in lean, and I can tell you in retrospect, I'm not impressed with where we've gone 2 or 3 years down the road. The true test is transforming the culture, a culture where people believe in transformation and are rewarded for transformation and can see it happening. They see the investment, they see individuals being engaged. When you have an opportunity to go and sit in a meeting and talk about it, and then you go back to your unit and say, no, they really are asking us how to solve this. They really are rolling up their sleeves and saying, tell us what you need. Don't tell us you've been frustrated for years and you guys haven't figured it out. Tell us how to solve this problem. So we truly are engaged. So when you find an organization that culturally has adapted transformation, to me, that's what makes the difference. Everybody is trying it because we're in a Me Too industry. If somebody's doing it, then you're eventually going to give it a shot either internally or with a consultant. But the most difficult part is developing a culture of transformation, and most organizations don't do that. And the senior leaders, the CEO, the physician leaders, the dean, everybody has to walk that walk. If you don't invest in it, if you don't support it, if you don't do rounds and celebrate it, people don't believe it. And those of you who've been in healthcare for a while have heard about the flavor of the month or the flavor of the year in all of your travels. It has to be something that sticks. When you look at organizations, Idea Lab, Google, that are known for transformation, when they talk about how they meet, how they reward, how they allocate resources, transformation is in the middle of all of it. And so everybody internally and externally knows this organization is committed to it. So they develop tools, they send people away to understand how to become a flywheel, so transformation just doesn't start, but it's sustainable, so it continues down the road. They continue to invest. The senior leaders exhibit it in their behavior and their decision making. So the difference is it's in the culture. It's not just a set of tools. It's not something that's tried. It's not something that consultants bring to the table. It truly is baked into the culture. That, of course, is the hardest thing to do. A culture of transformation and a culture of service, 2 of the hardest things to do in any organization. But it starts at the top.
Hello, my name is Nicole Rogers. I work in the Department of Nursing Excellence. I've been with the hospital for 3 years, and I'm an educator in my department. And I want to thank you so much for talking about transformational leadership, because that's one of my passions personally. Another question I have for you is, what is your why? One of my passions is re-energizing in our organization our why for why we're even here.
Mm-hmm.
So why do you, first of all, want this position, and why are you in healthcare?
Excellent question. Did you read the book about the why?
I did.
I could tell. Congratulations to you. I think I read it last year. I think last year was the year of the why, because at board meetings and everywhere else, people were talking about the why, and Simon Sinek is making a lot of money off of that why. But to answer your question, I got into healthcare many years ago because I saw an opportunity to bring some skills from engineering, from problem solving into the business to truly transform healthcare. The time I got into the industry, hospitals were closing, we were struggling with reimbursement, nobody knew what success looked like in the future. So it was an opportunity for someone with a non-clinical background to get in and try to contribute something. That's been my goal from day one, is to transform healthcare to deliver services to people who need it. I was an engineer, I was an automotive engineer, and I was designing cars and high performance engines, and as I reached a certain level of maturity, I realized my contribution to society needs to go beyond developing a Viper, as exciting as that may sound. The service industry, and specifically healthcare, provide that opportunity. Children, adults, people with chronic illnesses, health of a community, all of those are opportunities, and we have the tools and we have what's needed, but there needs to be a transformation to be successful in the future. Reimbursement is going to continue to change. Expectations for service levels driven by insurers, patients, and other customers are going to change, so we have to transform. So transformation, even before people were saying that in healthcare, was an interest of mine, and my specific interest here is because I truly believe when I look at your mission and vision and values, and when I talk to your leaders, they're committed to that. And committed, I don't mean you just have it in your pillars. When I read through the board activities, when I read through the community health report, when I talk to board members, community members, I'm hearing a consistent story. We truly want to get there. We're committed to it. And so this is the place where I believe it can happen, and it would be wonderful to be a part of that.
Thank you.
Thank you.
Hi, I'm Stephen Liu, and I'm one of the general surgeons here. Excuse me. In August, I'll have been here 18 years, and I've been fortunate enough to be the chair-elect for our Physicians Advisory Group here. And so I wanted to thank you again for coming, and I wanted to ask you to elaborate on two of the points you brought up, because they're really at the heart of, at every Physicians Advisory Group we have, concerns that we have. So first of all, you really mentioned the issue of physician engagement. Mm-hmm. And I'm sure that you've been told that we have the lowest physician engagement scores, essentially, of any academic health center in the United States. And so, first of all, what do you see as driving that, specifically here at UNM, and how will you address that? And the second thing is, you talked about efficiency and fiscal responsibility, and obviously that's a big concern for us, because we want to feel like we are contributing to the institution. And I think that a big frustration of providers is this idea that we are so facility limited, OR limited, bed limited, that really, Dr. Richards will tell you that the efficiencies of our operations are such that as we add patients, our efficiencies actually drop. And so how are you going to address that issue? So thank you very much for your time again.
Thank you. At least you started with some easy questions. So I can tell you once again from limited conversations that what I've heard about physician engagement is everything from transparency to communication to engagement in decision making to budget planning to alignment of planning with programs. So I've heard the things that I've heard on other campuses about physician engagement. You don't have to go to too many places to understand. Physicians tell us that these are the things that are important to us. You're either paying attention to them, or if you're not, and if you're not, don't talk to us about engagement. So the answer to the first part of your question, I'm hearing about those drivers as we put strategies together and as we have those conversations. We don't feel like our voice is being heard, and even in some cases, when you launch initiatives, we're not hearing about where they're going or what the follow-up is. So maybe some of them are dying on the vine, and nobody's talking to us about why. Maybe a decision was made, maybe we've reset course, but we're not being engaged in the conversation. So it's wonderful that we know and maybe jointly decided, but then what's the follow-up? Keep us engaged. One thing I'll share with you, that your competition for lowest physician engagement was Methodist and University hospitals in Indianapolis. So hopefully it's no coincidence that I've been on both campuses and engagement was low. But clearly I started this to tell a story, right? So when I arrived on campus, it was after launching an expense reduction program that was targeting $500 million over 5 years. So every year the academic medical center, 2 hospitals, was asked to take $100 million out of its expense profile. And I'll pause for a minute so you can choke on that, because that's what we did. Now that was established before I got there, so I can't take credit for that. So that was one thing. And then secondly, the decision making about programs, about capital, so forth, excluded the physicians. So when I arrived, the physicians were very clear. We're not engaged. This organization has lost sight of its priorities. So if you want our attention, if you want our cooperation, some things have to change. So the things I alluded to earlier, finding better ways to communicate, being transparent in our discussions and our planning, engaging them in budget planning, engaging them in capital planning, having regular meetings with physician advisory board, with chairs, with physician leaders, with the medical executive committee, doing regular reports on quality and safety and service levels and engagement levels, engaging them in conversations about how to address some of those engagement issues, having committees for the academic center of the future where those physicians led and could talk to their colleagues about what was going on. Those were the tools that we used to address those. We did a survey within months after I arrived where our engagement dropped to the single digits for physicians and to the teens for team members. And we talked with Press Ganey about what the potential was for improvement, because after that, of course, everybody's got to launch an improvement initiative. So we talked to Press Ganey, and they told us where you were prior to that. The physicians had fallen to single digits prior to that. I think we were 13th, 14th percentile. The team engagement had dropped to around 13 or 14. Previously was in the low 20s. They said, we've never seen an organization get back to a level that you were before, which is nothing to brag about. So we set about some improvement methods, the things I shared with you. When we did this survey the following year, we got back to the levels we were before. So we exceeded what Press Ganey had ever seen in terms of improvement by putting the foundation and building blocks together to address those. We listened, we followed up, we engaged, we asked them what kinds of things were important to them. It was just the beginning, because nobody's going to brag about scores in the 20th percentile. But we did demonstrate that we could do some improvement. And so by listening, by the way, we did back off of the $100 million a year expense reduction. That helped significantly. But we also changed the conversation. In our communication with physicians, with team members, in our regular meetings, we began with quality, safety, service, and engagement. Finance was no higher than the 5th item on every agenda. And we had gotten to the point where finance was first, second, and third in the conversation. And you really can't have that conversation with physicians. So does that answer your question?
It's a good start.
It's a good start. Okay. Did I leave anything out? You talked about engagement. You talked about efficiency. So efficiency, I'm sorry. So I forgot that one. You have a challenge of patient flow and physical capacity. I can tell you from struggling with the same things at Methodist Hospital, those are not going to be solved overnight. But there are 2 approaches that always work. One is looking at patient flow. And you've started some of those things, relationships with rehab hospitals so that you can get folks through. Looking at lengths of stay so that you've got the most efficient approach once folks come through the door. Limiting readmissions, making sure admissions are appropriate. So looking at the steps, the processes related to patient flow has to happen right away. I know you're doing some of that, but you've got to have measurable improvements with patient flow so you're getting the most out of what you got now, because you can't build things fast enough to address capacity. So the first thing is to do the patient flow, and those are the steps we put in place in Methodist to address issues, because we were turning away patients. We were turning away the very patients we were asking our surgeons to get us from neighboring hospitals. The second thing is to critically look at capacity and see what you need to build. And that is a decision that has to be driven by objective measures. You know, one of the mistakes we made at Methodist is when we had our capacity issues in our conversations with physicians, they said, well, let's just build more beds. We have got plus or minus 700 beds operating. We can't get folks in, just build more beds. All the projections we had for the future was that we were going to need fewer beds. So you have to make careful decisions about what the capacity should be for the future and not react just because that you're having capacity issues. What do you really think the future is going to look like, and what do the experts inform us that the need is going to be in the community for the future, so that you're building the right thing? And you know, once you set that course, of course, you can't get those up fast enough, and you do private rooms, which gives you more flexibility. So getting the right capacity, having relationships in the community, talking to your partners about maybe some things that they could be doing with inpatient capacity and maybe ambulatory capacity that you're taking on now that you don't necessarily have to. The strategic choice about what's most important to us. I mentioned the drivers at Methodist University. We had to make some critical decisions about the 5 things that were most important to us, that we were doing the most of, we were the best in the region for. That was our focal point. Some of the other things that were taking up capacity, we had to make some decisions that maybe we shouldn't be doing them, or maybe we can't do them right now. And if a cardiac transplant or cardiovascular surgery admission, or some of those, those high-end cancer admissions were being delayed by some of the admissions that didn't need to be there, then we had to critically look and say, let's increase capacity and see those patients somewhere else. That's a decision that's hard to do, but you have to have it with your physician leaders. So I wish I could give you a tomorrow solution. I've never seen that solved that quickly. But you have to put steps in place to address flow and to look at capacity, to make some tough strategic decisions about what needs to come in. Those things you can do fairly quickly. You can't build overnight, but you can do quick hit patient flow things in exercises that take a week or 2. Now you still got to implement them, but you can sit down and talk with physicians and other team members and do some of the patient flow initiatives right away.
So you brought up one very big issue, which is that the mission of the institution. And so I think that, I don't want to take everyone's time, but there's a huge safety net mission of UNM. Mm-hmm. And there's also a very important tertiary care, high intensity, high resource mission of UNM. And so you just, basically in that example you gave, right, you sort of brought up the fact that essentially those 2 missions are contradictory to each other.
I hope I didn't say that, because I don't believe that. I don't believe that. Your strategy would not be sound if those were contradictory. The way to achieve them may be different than what we've done in the past. So I hope I was clear about that. Being the community provider is important. It may not mean that we take every community patient, but ensuring that the community has the services it's needed is important. The high-end things that UNMH does best, we ought to be doing. They can't go anywhere else except outside of the state. So we want them to stay in the state. That has to be where we start. But it is a challenging strategic conversation about what capacity we have to do, inpatient and ambulatory. You start there and you make some tough decisions. If the decision is, here's what we are going to do that's quaternary and tertiary care, and here's the capacity, as we have the concentric circles of other things that we can do, and you reach a capacity limitation, then you shift the conversation to how do we get this done? The way to get that done may not be building more x-ray rooms and more patient beds. There may be some more creative approaches. There may be approaches outside of the hospital. There may be ways of avoiding admissions. So there are a lot of solutions, but I don't think you have to abandon your mission to be a community provider because you're an academic medical center. Now, you could build 1,000 beds and do everything else, but you got to pay for that. And you'd have excess capacity, and you wouldn't be a good steward. So you have to start with, what are we going to be in the future? What capacity do we need with the best patient flow we can possibly achieve? And then for the other needs that we've committed to, how do we get that done? So I believe we can still embrace that. There are just different ways maybe of solving that than just building more beds. When you look at the cost per beds, the conversation quickly changes. And when we talked about Methodists, the docs wanted us to commit to 700 beds. When we showed them what that would cost, when you multiply that by dollars per bed, it was over $1 billion. We didn't have $1 billion project capacity. So we quickly had to back away from that. Even if we thought it was the right thing to do, it just wasn't feasible. So we had to have that careful and difficult bed conversation and then start with what is our mission? What is our ordinary and tertiary mission? And then how do we achieve other things? We did it there by using our sister hospitals and partner hospitals. Now that was a system. This setup is a little different. We don't have 12 other system hospitals. But it led to the conversation of how are we still responsive in our community, and that may not mean all of those patients who come into beds today are going to be the same ones to come in the future. So is that clear? I don't believe those are contradictory notions. I'd be happy to engage in that conversation further, but I'm not suggesting that you abandon that mission. I'm suggesting that you figure out strategically and resource-wise how to accomplish that, and then have those tough and creative conversations of how do we achieve the rest of our mission. Improving the health of the state is a huge, huge ambition and can be achieved. Probably not best achieved with all the methods that are in place today.
Good morning, Mr. Buchanan. My name is Preston Burgess. I'm a quality consultant in our quality department. And I have to say that your message is very high level, and it speaks to a vision, and I think it resonated with a lot of people in this room. I've also worked here for 18 years. I started at the information desk. So we know that patient care doesn't stop. It's 9 o'clock in the morning for CEO town halls. And so a lot of people who might want to be here cannot because they're taking care of patients or giving directions, whatever. So would you change your message at all if you had a room full of frontline employees? And if so, what would that be?
I'd like to say I wouldn't change it at all. When I say that I'm approachable, one of the things I want to indicate is that I'm willing to have this conversation with anyone who has an interest or who has some input into it. So I would welcome that opportunity to have this conversation with frontline employees. Certainly, I would tailor some of the comments to things that I thought were more relevant to them, or maybe were challenges for them, or things that they had been worried about in the past that they didn't feel like were adequately addressed. But the same themes, the same vision, I would share with them, the same potential, the same desire to invest in them. A couple of examples I didn't share, we had an employee advisory committee the last 2 places I've been where I met with employees on a monthly basis and talked about their agenda. I didn't have an agenda at all. What was on their mind? And we used that platform to talk about everything from what was going on to the organization, to how we were going to change leave policies, to how we were making decisions about time off for community service. We tested new ideas on them to get feedback. When we launched things, we used them as a sounding board to say, how is this going to be received? So I welcome and embrace the opportunity to talk to frontline employees about all of these things. And that would be one of the first things that I would do. In fact, I'll share another short story. One of the ways of being introduced at Methodist Hospital was to walk around with the AV team and talk to people about the new CEO. And at that point, they didn't know who the new CEO was. So I could just talk with them about what was on their minds and what their expectations were about the CEO. And you'd be amazed at what people will share with someone they didn't know with their CEO about what they're expecting him to do. It was a bit of an eye-opener. But just sharing that to say that engaging with team members is critically important, and that has to be a top priority of the CEO. So I could easily see Fontaine trying to track me down the first 90 days because I am wearing my shoes out just trying to have as many conversations as possible. And I'm not indicating that I'm not going to be at board meetings or senior team meetings, but I remember reading about a leader years ago that 30 to 50% of his time was spent investing in the organization. And that was one-on-ones, it was rounding, it was just having hallway conversations, and I was impressed by that. This was Jack Welch, who's known for building a multi-billion-dollar company, but as he progressed in his career, he was purposeful to say, if I'm not spending up to half of my time investing in people, I'm not a very good leader. I haven't gotten there yet. Did that answer your question?
Absolutely, thank you.
Hi, my name is Terry Young. I'm going to do my EDIT. So I've been a nurse for almost 22 years, almost 18 of that here at this organization, from a staff nurse to a charge nurse to a unit director in 2 different units. I'm currently the unit director for the Children's Psychiatric Center inpatient unit. And one of the things I wanted to ask, it's kind of 3-part, is we're kind of on a journey to magnet. So first part of my question is, how do you engage nursing and the other disciplines? You've talked about physician engagement, but how are you planning to engage nursing and the other disciplines who, are at the bedside greatly affecting patient care? Second of all, how do you make sure that these disciplines are, or what do you envision for these disciplines as being part of the leadership of the organization? And then kind of, how do you see moving forward from a practice model, their involvement in the multidisciplinary team?
Ooh, 3 good questions. So the first one is the easiest one. How do I engage nursing in the magnet conversation? I take my instructions directly from the CNO. One of the first things a successful CEO learns in this business is take your marching orders from the CNO. And I don't mean to be just comical about that, but what I have found in now the 3 magnet organizations I've been in is partnering with the CNO, one, to show visible support for magnet, but understanding what's needed from the nursing leadership. I consistently meet with nursing managers, nursing directors to hear what's going on, but specifically as you get closer to the magnet journey, what do you need from the organization? What I understand from magnet is they don't want to just see quality and service and processes. They want to see that the whole organization is embracing magnet. One of the things they ask, in my memory, is they ask the senior leaders to publish statements about nursing and nursing leadership. And so I'm happy to do that to make sure that they understand that nursing is a critical part of, perhaps the most critical part, if I can get the physicians to plug their ears for a minute, about the organization and where it's going and patient care delivery and coordinating teams to make sure that patients have what they need. So I reach out to nursing leadership and say, what do you need? I have some ideas from what I've done in the past, but to understand what's most needed here on your journey, I would start with CNO and nursing leadership and say, what do you need from us? What do you need in terms of resources? What do you need for statements? What do you need the organization to do in how we meet, how we publish our strategy, whatever, to demonstrate that all of the pillars of nursing, which I believe are aligned with the quality and safety initiatives and service initiatives of the organization, what do you need to demonstrate support for that? Because what I would like, whether it's magnet survey or joint commission survey, I'd like to be in a position that when they come, we're just showing off what we do. We're not doing the 24-hour, or we think, somebody checked in over the weekend, they're going to be here Monday for the survey. And I know other folks say this, but I'd like to be in a position where we're doing so well that when the surveys come, they're taking notes because they want to go back and say, here's what UNMH is doing. They're doing some fantastic stuff, rather than finding things that they can cite and say, well, you're not quite there yet. I've been a part of, I think, 4 successful magnet surveys, but the short answer to the first part of your question is, I'm willing to do whatever the nursing leadership needs to make sure that we're successful. And that direction most specifically comes from your nursing leader who has even trained Dr. Richards, I understand. Now the second part of your question is, where do I see nursing and nursing input in the future? So their role is as pivotal as any. I don't necessarily like to establish a hierarchy. This is about team engagement. So physicians, nurses, techs, housekeepers, cooks cooks and techs in the OR. Everybody has to be a part of helping this organization achieve its mission, vision, and goals. Certainly, nurses are a leader. They're touching patients every day. They're part of they're at least connected to the nursing school, so they're part of discovery. They're part of training. They're interacting with physicians and team members every day. So they have to be one of the top leaders. So I look to them to define where care is going in the future. So as an example, when we get to the conversation about patient units and work areas and whatever else we have to build or renovate, The nurses have to tell us where things are going in the future. We don't want to build nursing stations and nursing units the way they are in the past. We want to build them, one, for the future, but also with a flexibility so that as care models change, we're prepared to do that. I need to engage them in conversations about physicians. You can't just talk to physicians about physician engagement or building a model or operating a clinic or doing rounds. Nurses have to be partners in that conversation. Similarly with quality, when you're talking about quality improvement, there has to be a partnership with physician leadership and nursing leadership. So I see them in the middle of every element of leadership, not only on the things directly related to patient care, but everything that's going on in the organization. Team engagement, compensation, and benefits. So I look to nursing leadership as, generally when you look at the population, the staffing, nursing leadership can be what, plus or minus 40% of staff, maybe more? So clearly they're a key element in every conversation you're having. What kind of food are we having? What's the quality of the food? What should the entrance look like? What can we do for the front desk? I want to engage nurses in all of those conversations, if that answers your question. Now you said 3 parts. Did I miss one? So multidisciplinary teams fortunately have been embraced in the recent past. So I see more and more planning and execution. Certainly when I look at patient care in the future, it's multidisciplinary. I think in many regards, particularly in academic settings, many of the approaches to care have grown up around, if I could say this, the convenience and the processes of the caregivers and not necessarily the patient. Patient-centered care, I remember, was all the rage maybe 20 years ago. And I don't know many organizations that truly achieved and embraced that. But with expectations increasing and folks looking to us to do things that they are getting everywhere else outside of healthcare, I think multidisciplinary and changing our approach to patient care and engaging patients in that conversation is going to have to be accelerated. We have to do better than what we've done so far. I'd like to be able to walk into a patient room and have them tell me a different story than what I hear now, rather than questions about the number of consultants who came through or the nurse and the physician not talking with each other, or once I'm discharged, what should the communication be? What's the plan to be? How do I prevent a readmission? If I'm in an environment where I can't get all the things that are on this discharge list, what other things can I do? So I really see the nurses helping to lead that multidisciplinary, patient-centered conversation. And I think you're the experts. I look to you to tell us where that's going to go.
So I think we may be down to maybe the last or maybe the second to last question. And I'd just like to make sure that if we have any community members in the audience that would like to ask Mr. Buchanan a question, that we give you an opportunity. So if so, please raise your hand. And we'll go with the next question, please. Great.
Hi, I'm Johnny Jones. I'm the manager of Women's Imaging and Women's Imaging Outreach. And thank you again for coming to speak with us. From your history as a transformational leader, I'm going to make the assumption that not everything went exactly as planned. How did you take one of those failures and actually use those lessons learned as an impetus for future success?
That is a good question. You've interviewed people in the past, haven't you? So I have also learned from following leaders that sometimes you learn more from failures than you do from successes. And I'd like to be able to walk around and tell folks, I don't know anything about failure, only successes, so maybe I didn't learn that much. That's not the case. I have many, many examples to share. So the one that I'll share with you is a disappointment we had at Indiana University Health. I mentioned to you that we were engaged in this big idea conversation. And for the first time, we had sessions with folks outside of the industry and bringing us some breakthrough ideas like the service profit change, which sounds simple, but was elementary. If you invest in people, if you hire the best people, train the best people, give them resources, ensure that they have processes in place, they will get it right, and then profits will follow. So get away from this focus on money, money, money. If you do the core business the way people got in the business to do, you will be successful. So they brought bright ideas to the table, and we put those things together and began to incorporate them into our planning for the academic health center in the future. So there was this huge breakthrough, and we were prepared to publish. We were incorporating this in our planning, and we thought this was the beginning of not only planning for the academic health center in the future, but transforming the organization. So we put that in place, and then there was a significant transition in every element. The system leadership transition, the project transition, the capital available changed. We brought in a new leader at the system level for construction, and so we had to change the approach. We got a new CFO who wanted to go back and revisit some of the capital decisions, and so the short story is we lost track of the big idea. So something that had the potential to really transform the organization and how we thought about things in the future, we lost track. And so, it became one of those grand plans that collected electronic dust. We knew better than to just put it in a document and sit it on the shelf, but it collected electronic dust. And so the danger was we engaged so many high-level folks in this conversation about the potential, which was the right thing to do, but then it became, once again, in IU Health, one of those things like lean, like some other things that we talked about and then faded away. Now, the lesson learned from that, of course, is you cannot do enough homework to ensure that you've got every constituent on board so that these initiatives survive everything. Healthcare is an environment of transition. CEOs are going to retire, senior leaders are going to move on, programs are going to change, people are going to move into new roles, the community is going to change, budget's going to change, something's going to happen at the legislative level. If you truly want to transform a culture, this wasn't built to survive that. Without the individuals who launched it and without the infrastructure of the AHC of the future, including the architect, continuing to focus on it, it wasn't going to grow legs. And certainly I knew elements of that before, but that was one of the more visible disappointments because it had so much potential. So the lesson from that is you have to do everything possible so that initiatives survive the leader, the year, the budget, the strategy. If you're doing the right things, if it's consistent with your strategy, mission, vision, and goals, it should survive. And you have to make sure you do everything possible, from communication to engaging the right people to getting folks in the organization excited about it so that you truly do have that flywheel and it survives transition. We're in an industry of transition. I've seen it my whole career. That's going to continue to happen. The things that this organization commits to that become the fabric of its mission have to survive transition. You've done some things that are going to survive Steve's retirement. You know that. You're comfortable with that. Those are the kinds of things we're talking about that we have to build for the future.
Okay, well, I think we have one last question, Mr. Buchanan, and then we'll...
Hello, my name is Gloria Doherty. I'm the Executive Director for the Inpatient Advanced Practice Providers as well as Respiratory Therapy. And you kind of already answered my question in a previous one, but I stuck with the microphone. I've been here for like 15 years, and I wouldn't dream of working anywhere else because I love the mission and the vision and the people who work here.
I'm glad to hear that.
Yes. So my question was surrounding the ability for all of our licensed personnel to work to the fullest scope of their training. Our respiratory therapists don't do everything that they can currently. Our nurse practitioners in this state, as opposed to Indiana, are independent, as well as several other broad differences in the Nurse Practice Act for our registered nurses that can do so much more than they currently are. So just wondering, as we're working with limited resources in this state, what your feelings are for supporting that Institute of Medicine report that we work to the fullest extent of our scope.
Excellent question. That, of course, is a key to achieving the kinds of efficiencies we talked about. Now, we cannot afford, as I mentioned earlier, to practice the same way we have in the past and do all the things that we want to do, which means people have to be able to provide at the top of their license. Traditionally, there have been barriers to doing that. Some of them were legislative, some of it were other team members that felt like maybe there was some infringement on their territory. But engaging the conversation is the key to ensuring that folks can operate at the top of their license. First, of course, having the conversation with the various caregivers, the APNs, the respiratory therapists, about what they could and should be doing, and then more broadly engaging the teams about how to get that done. No one can argue that best leveraging the resources we have is optimal. People may be threatened by seeing other folks do things that they traditionally did, but that's part of a transformative organization. When you talk to some of the folks who are most concerned about people moving into their territory, they will also share with you all the other things that they want to be doing they don't have time to do. So that leads to the conversation about why wouldn't you want to free up some of that time by having other folks do those things, and you're able to focus on things to do at the top of your training and license. So those are tough conversations to have, but we have to do it. We want to create efficiencies that are relatively painless so that we can get more out of the resources we have, do some expense reduction or more with the current resources we have, by not doing the old-fashioned thing of just fewer people than we had the previous year. And that means people operating at the top of their license, multidisciplinary approaches, and the only way I know how to do that is to engage them in conversation and to continue to ask the why questions when folks say, well, that isn't what they should be doing, or that's what we should be doing, or 3 or 4 folks are licensed to do the same thing. The important thing is to get those things done and let people come to work and feel like they're doing everything that they're capable of doing. We can get there. They're not always easy conversations to have, but if you start with the patient and you talk about patient flow and services and what needs to be done, you get the right people in the room, you can put a process in place that works. And then if you have some success in one area, then you can multiply that to others. I've had some successes with that. Excellent question.
Okay, well, Mr. Buchanan, thank you very much for sharing your vision, and also thank you for everything that you've done for healthcare, in your communities and nationally. And I'd also like to just thank everyone in the audience today for participating in this process. This obviously is a very big position for our community. We play a very unique role in New Mexico, and UNMH is the anchor of that healthcare mission that we have. And so this is an important process, and your input is very valuable here. So if you could please remember to fill out those evaluation forms so that we can get your feedback. And again, thank you very much for being here, and thank you for everything that you do every day for us and for New Mexico.
Thank you. Thank you.